I think we have around 6 to 7 minutes time. I'll ask one question each and let me see if there are any other question. First to Dr. Jay Shah. Sir, why is it advised to avoid SGLT2 inhibitors in patients with severe illness?
Yeah, very nice question, sir. In severe illness and in a surgical setting, I think SGLT2 inhibitor should be avoided because it is proven to produce euglycemic ketoacidosis, and that is something which is very detrimental, especially in a critical illness or a critical either a surgical illness or a medical illness, which is more prone to develop more of a complications. And we all know that SGLT2 inhibitor is a glucose dependent mechanism, and it produces a euglycemic ketoacidosis. So any condition which is responsible for prolonged hospital stay, prolonged fasting level, where there is not a proper oral intake, these are the conditions which can lead to more of a ketonemia and ketonuria. So these are the things which we must educate and you keep in mind before prescribing SGLT2 inhibitor in this critical illness.
Yes, sir. Thank you, sir. You're right, because during severe illness, the counter-regulatory hormones are very high, especially glucagon, and that will actually counteract the effects of whatever small amount of insulin is there. So the next question to Dr. Jayalakshami, what do you think is the role of SGLT1 and SGLT2 inhibitors? Is it safe to be used in patients with CKDs?
Basically, the SGLT1 and 2, the drug that inhibits both, has been found to have a lot of side effects. Because of the cumulative inhibition downstream, I think this needs to be evaluated and more trials have to be done, and selective drugs may be required in future. So I don't think it's correct to use simultaneous inhibitors at this point of time.
What's the role of sotagliflozin, which also has a combined SGLT1 and SGLT2 inhibition?
Yeah, it's been shown to have a lot of side effects. So I think that needs to have a further evaluation. A sequential inhibition may do more bad than good. That has to be found out.
Fine. To Dr. Arundhati, is steroid use associated with worse outcomes? You have seen that left and right people are writing steroids in patients with even mild COVID infections. So what is your comments on the use of that?
So indiscriminate steroid use is associated with worse outcome, I would say, where needed, because it's a double-edged sword. At times, we do need to use in a lot of patients with severe COVID-19, and there it's absolutely all right. But what needs to be emphasized that a lot of times steroids are being used, but the hyperglycemia part is not being taken care of as it should be. So when steroids are used, we need to understand that this is going to cause a rise in sugar levels in the non-diabetic or the newly diagnosed. That has to be aggressively managed. And indiscriminate use, from the word go, we have WhatsApp prescriptions with steroid being prescribed there. So that kind of use that really needs to stop right away. Right.
Okay. I'll ask one question to Dr. Jay Shah. What do you feel is combining SGLT2 inhibitors and SGLT1 inhibitors? I think next I'll hand over to Dr. Ashok Dutt. He will ask the questions.
Yeah, so combining SGLT1 and 2, they are the area which further requires little more strong data. We have a lot of data regarding SGLT2 inhibition. The important thing what we need to see is the affinity of SGLT1 to SGLT2 with the different molecule. As we are aware that empagliflozin has got the maximum affinity for this particular SGLT2 inhibition as compared to SGLT1, and as Jayalakshami ma'am has already said that by using this two molecule, I think we are doing more bad than the good, and that is probably the more robust data are required before going ahead with this type of combination in our patients.
Over to Dr. A.K. Das, sir. Are there any questions from the audience, sir?
Box, but I must thank you for doing a wonderful session, and the three speakers of the module 1 have done exceedingly well. Ganapathi, your leadership has been great. I have Ganapathi, as usual, I'm very sorry I couldn't introduce you, but I must say that the proverbial president of the ESI, He has been the top of the world in the field of endocrinology from the St. John's and everywhere in the country, winner of many awards. I have no time now to dilate upon it, but I must tell you that wonderful session. I think please allow me, Ganpati, to take the key home messages just to re-emphasize and
Sure.
ask one question if time permits. Number one, my dear audience and the esteemed Module 1 faculty, I must tell you, the most important message Jay gave was about the gap between the innovation and the adoption. Am I correct, Jay Shah? He
Yes.
said, are you there yet? So that was the message that we want to give to the audience, that there's a great gap in our country in the adoption of the innovation and the adopting it in theatre practice. Today, we have the SGLT2 inhibitors, which are affordable. I'll repeat again, affordable, because the DAPA has gone off patent. It is affordable, available, accessible, and Jay has put beautifully. Of course, Jayalakshami also, that, and also Arundhati, that are the most appropriate drugs to treat, be it the cardiac failure, be it the cardiovascular risk factors, be it the DKD, or be it the initial treatment of the COVID-19 and diabetes. Arundhati beautiful brought the point that SGLT2 before their trial, even after their trial, has said it has to be continued. There's a lot of cardiovascular, am I correct, Arundhati? Lot of cardiovascular and other organ benefits built in the SGLT2. So this molecule has to be used more. That's the first message. Number two is that you have shown in your beautiful presentation, Jay, that the DAPA-HF Empareg has beautifully shown the reduction of the MACE, the cardiac events, by at least 15%. And you have to also show the DAPA-HF trial that it prevented the death because of the heart failure and the hospitalization rate because of the heart failure. Wonderful data. And I must also tell you that you have said that this drug has to be used appropriately, maybe quite early in the disease, because it will prevent. I always give the example. Ganapathi and been in many forums. The two American presidents. One president died because of tuberculosis when ATT was not available. Other American president died of hypertension when Pickering and Platt were discussing whether to treat hypertension or not. So I would say, when the DAPA has become most affordable drug today, not to use it, I will not say crime, but not good. Appropriately, it must be used. The second issue that you brought to the forefront, Madam Jayalakshmi, Madam, you have given the great message. I must tell you that you said beautifully that the DKD is at least 1/3, 35%. Wonderful, Madam, have DKD. So it's a message to all of us that we must screen for the diabetic kidney disease. How do we screen? Urea, creatinine, albuminuria, EGFR calculation. And it is great to screen for the diabetic kidney disease, and along with the RAS blockade, along with the other drug that we use, SGLT2 is very, very beneficial. And you said that both in the DAPA kidney trial and the EMPA kidney trial, both have shown great benefit of this molecule in preventing decay. So that is the message, and how it does, you have beautifully explained. I will not get into that, but both you and Jay beautifully said that the dual trial, trying both sotagliflozin, both SGLT1, SGLT2 blockade, the two trials have been done, soloist trial and the SCORE trial, and both the trials, as both have pointed out, have not shown much benefit, more side effects. So I will again suggest, let us confine to what is available in our country today, that is the SGLT2 inhibitor. And you beautifully said that if we use this wonderful molecule early on in the disease, along with the heart, will prevent the decay. And you also talked up with the point that the kidney patients die mostly because of the heart disease. Am I correct, Madam? The type 2 diabetes, yes, they die of the heart disease. So my message to the audience, take home message, please use SGLT2. DAPA is available freely. Please use it to prevent full-blown diabetic kidney disease, to produce immense benefit. Arundhati, I think she is, as usual, beautifully touched upon the point of COVID-19. But Arundhati, I think I would say one thing. Your message is loud and clear that we have to control hyperglycemia in type 2 diabetes to prevent COVID. And you get the message that this can be metformin, a repurposed drug, and also can be SGLT2. You said Previous years, DPP-4 had gained importance, but today both DAPA and SGLT2 are indicated. Also, other drugs are also indicated. You also said, very important fact, which you have published recently, and the petition is going around the country, that blood glucose estimation must be the fifth vital sign. I think Jay and Jayalakshami, Arundhati, me, and our group has given a petition that, pulse, BP, temperature, respiration, next must be blood glucose. And that has been proven beautifully in the COVID-19 epidemic, where the hyperglycemia is proportional to the worse outcome, to the death, to the post-COVID, what's called long COVID symptoms. Therefore, blood glucose has to be controlled. And if we control with a drug which has multifarious benefits, you may not use it in the ICU, may not use it in the oxy ward, but before COVID comes, it gives lot of benefits. So hyperglycemia before, hyperglycemia on admission, hyperglycemia after admission has to be controlled very, very effectively. I think I'll stop here. Thanks. I must congratulate all the three wonderful faculty, and above all, my very dear Ganapathi, for your wonderful moderating of the session. Thank you very, very much.